Good morning. First of all, I would like to thank Dr. Dina for choosing me. It's a great opportunity and privilege. First, I would like to thank my mentor, Dr. Ahmed Rida, because he chose this case and he guided me how to approach this case and also provided me with more videos of similar cases. And also, I would like to thank Dr. Heb Abdurrahman for perfecting this presentation. A 9-year-old female patient came to the Squint clinic with her mother, complaining of defective ocular motility that started to be noticed at the age of 2 years with a relatively stationary course. On examination, her uncorrected visual acuity was 0.7 in the right eye, 0.25 in the left eye, and best corrected 1 in the right and 0.7 in the left. Manifest and cycloplegic refraction as follows. We started to do ductions in both eyes. We can see intact both motility in the up gaze and down gaze, and scarcely no, very little or even no lateral gazes. On versions, we can see the same. Normal down gaze, no lateral gazes. She also moves her head to the sides to look to the right and left, but no dextro or levo version, normal up and down gazes. To summarize extraocular motility, we have severe limitation of abduction and adduction in both eyes. The cover test showed small angle XT, about 20 prism diopter in both near and far, with and without correction. We also noticed a lift hypertropia of 10 prism diopters. Anterior segment is free, fixation is central steady maintained in both eyes with right fixation preference, no nystagmus, and fundus more or less within normal. On further asking the mother, she claimed a deformity in the back started at the age of 2 years of insidious onset and progressive course. Investigations were ordered as follows. First, we ordered an MRI brain with some close up to some scans in the axial and sagittal. I will discuss the findings in these scans later. And the report of MRI showed evidence of brainstem cleft with non-decussating white matter tracts for genetic analysis. Also, we did X-ray spine, which showed developmental dorsolateral scoliotic deformity. Also, pentacam was ordered because we had some astigmatism in the left eye, which only showed just bilateral asymmetrical vertical bow tie with bilateral withdrawal astigmatism. So, the only diagnosis we have in this case of horizontal gaze palsy with progressive scoliosis, it's a disease entity, which is an autosomal recessive disorder caused by ROBO3 gene mutation on chromosome 11. A mutation in ROBO gene were found to lead to non-crossing of selected axonal paths in the CNS that normally cross the midline during embryonic development, characterized by absence of conjugate horizontal eye movements and accompanied by progressive scoliosis developing in childhood and adolescence. So if you want to talk about the pathway of conjugate horizontal eye movements, normally it originates in the left premotor cortex, from where fibers cross to the contralateral paramedian pontine reticular formation, which fires to the nucleus of the sixth nerve nucleus and causes contraction of the lateral rectus. And also from the sixth nerve nucleus, internuclear neurons pass up at the level of the bones through the medial longitudinal fasciculus to the contralateral third nerve nucleus, which causes contraction of the medial rectus, and this causes, in if we are talking about the left premotor cortex, this causes dextroversion, and the opposite causes the levo version. This is the normal in the normal cases. But in this case, there is failure of crossing of axons at the level of the pons, which is the level of crossing of fibers from the nucleus of the sixth nerve to the medial longitudinal fasciculus. And also there is a failure of crossing of axons at the level of the medulla. In addition, there is absence of the facial colliculus, which includes the sixth nerve nucleus. In this diagram, we can see two prominences at the dorsal aspect of the pons, and this is called the facial colliculus, which mainly contains the nucleus of the sixth cranial nerve and fibers of the facial nerve winding around the nucleus and emerging from the ventral aspect of the pons. So the radiological findings characteristic to the horizontal gaze palsy with progressive scoliosis are: number one, the cleft pons sign, which is pathognomonic to this case. Number two, absence of the facial colliculus, as we saw in the diagram before. Hypoplasia of pons and medulla, tenting of the fourth ventricle, and butterfly-shaped or rectangular-shaped medulla. In this case, in this axial scan, we can see clearly the cleft pons sign. Also in this sagittal scan, we can see tenting of the fourth ventricle. We can also see there is nearly no prominence in the dorsal aspect of the pons. It's allowed to be concave surface with hypoplasia of the pons and medulla. And in this scan, we can clearly see the butterfly-shaped medulla. So what about the skeletal deformity? Why is this horizontal gaze palsy associated with the scoliosis or the kyphoscoliosis? ROBA3 mutations in human neurodevelopment is responsible for uncrossed nature of both the pyramidal and the proprioceptive sensory systems. Actually, there are many hypotheses, but one of them, it was found that a genesis of fibers within the inferior cerebellar peduncles, which contains the fibers that receive and convey proprioceptive information from the posterior column and the vestibular nucleus to the cerebellum. The agenesis of these fibers lead to spinal deformity by impairing proprioceptive signals from the spinal cord, which is critical to drive locomotion and regulate muscle tone. أو بمعنى آخر يعني أنا بشبهها لنفسي إنه this child is unaware of the position of his posterior of his spine or his vertebral column in relation to space, and this unawareness leads to the absence of any corrective movements, and this causes the progressive deformity of the spine. Why did we order Pentacam? Because there were some papers that suggest that the compound heterozygous mutations of ROBO3 gene was found to be associated with keratoconus, so patients with horizontal gaze palsy should be searched for ectatic changes. These are the further videos provided by Professor Dr. Ahmad Rida. We can see clearly the normal up and down gazes, but with nearly no lateral gazes. This case also has nearly normal up and down. There are some sort of aberrant innervations, some twitching and some ptosis that occurs. Normal up and down gaze by Doll's maneuver, but no lateral gazes. Also this case, normal up gaze, no down gaze, normal down gaze, but no lateral gazes by Doll's maneuver. This boy had this scoliotic deformity for which he wore a belt for some time till the time for surgery. He did surgery to correct his scoliosis. Another case, normal down gaze, normal up gaze, but no right or left lateral gazes. Also this case, which seems to be symptomatic. So if we are talking about the differential diagnosis, this case is clear to be a horizontal gaze palsy with progressive scoliosis. But to talk about any differential diagnosis, we have to put in mind is Mobius syndrome, which includes both horizontal gaze palsy and mainly Stevens or facial palsy, bilateral facial palsy, and they have this hypoplastic muscles of the face and facial, like a mask face with no facial expressions. Also, Mobius syndrome has other cranial nerve pulses like 12th cranial nerve, and they have hypoplastic tongue, maybe sometimes third and fourth cranial nerve with ptosis, and some esotropia. Also may be associated with fifth cranial nerve, eighth cranial nerve. It has multiple cranial nerve pulses. Also bilateral Duane type 3 syndrome, we can put it in the differential diagnosis. But the radiological findings makes it clearly that it's a horizontal gaze palsy with progressive scoliosis. Thank you.
Thank you, Christine, for such an interesting presentation. This is one of the cases لو الواحد it's not aware of it يبقى مش هيعرف إن هو يشخصها. Actually, when you just see it once, you'll always look for it. Detecting it early برضه بيخلي فعلا ساعات كتير بنوقف البروجريشن بتاع السكوليوزس ده.
هو زي ما انت وريتي بالفيديوز كمان الكونفرجنس بيبقى انتاكت عندهم، يعني في الصور باينه قوي في الفيديو ان الكونفرجنس انتاكت. الحاجه الثانيه كنت احب ان انت قلتي عنده هايبوتروبيا في الليفت اي، كنت احب ان انت توريني في الهيد تلت الهايبوتروبيا دي هيبقى اخبارها ايه. تمام، يعني عشان نبقى ماشيين سيستماتيك. صحيح المفروض ان احنا تؤكزامن في اللاترال جيزز، بس هو ما عندوش لاترال جيز، بس على الاقل كنت احب كده. وكنت احب ان انت برضه تشوفي الفيجوال الستيريو اكيوتي عنده اخبارها ايه، عشان هايبوتروبيا دي ممكن كان افكت. يوجوالي هم اورثوتروبيك في البرايمري بوزيشن، المفروض ان الستيريو اكيوتي تبقى نورمال.
برضه في الديفرنشال دايجنوزز I think ان هو الانترنيوكلير اوفثالموبليجيا وال1.5 syndrome is one of the yes.
وبعدين هو المفروض ان الدكشنز، يعني الناس اللي عندهم جيز بولسي زي الانترنيوكلير مثلا اوفثالموبليجيا او ال1.5 syndrome بيبقى عندهم الدكشن نورمال، لكن انت وريتينا ان هنا حتى الدكشن افكتد، يعني وده اللي احنا ليه بنعمل دكشن وفيرجن عشان نفرق بين الجيز بولسي لوحده ولا الانديفيدوال ماسل بولسي.
Thank you.